right, so good morning. Welcome to Urology Grand Rounds. Today we are going to be having two talks by sub-interns who have been with us here at Yale. I just wanted to introduce, so this morning for our Grand Rounds, we're going to have two talks. The first talk is going to be by João Porto, and he's going to be discussing ureteroscopy with laser lithotripsy in the treatment of urinary lithiasis in the pediatric population. Okay, and then we are going to be having a talk by Cassandra Schuster, the role of hyperbaric oxygen therapy in urologic disease. Is it justified? And I would just ask if people would turn on their cameras if they can, just so we have a better presence. So we're going to start with Joe.
So good morning, everyone. Thank you for having me. My name is João Porto, a fourth-year medical student from Brazil. I had my sub-I with you in Yale in the mid-August to mid-September. And today I will talk about the ureteroscopy with laser lithotripsy in the treatment of urinary lithiasis in the pediatric population. It's a study that we did in a certain hospital in my city, Rio de Janeiro. So, and we compared our numbers with the literature. So to begin our presentation, I'd like to talk about the historical documentation. Urinary lithiasis is a disease with long historical documentation. So this paper here, for example, can illustrate that we have stones inside the bladder of mummies with almost 5,000 years old. So because of that, these kinds of disease, we always try to deal with that, created modalities of treatment. And in the 80s, we had a big revolution with the development of the extracorporeal shockwave lithotripsy, which is a kind of treatment that it's non-invasive and it fits pretty well in the pediatric population because these patients, they have a smaller urinary tract. So even nowadays, it's the first line, the gold standard in different situations. However, in the last years, we have the improvement of the andrology, mainly represented by the PCNL and ureteroscopy. The PCNL has gained more space, especially because of the mini PCNL, micro PCNL kinds of treatment that fits pretty well in the pediatric patients. And the ureteroscopy, they are gaining more. It's gaining more space, especially because the improvement of the miniaturization of the instruments and the improvement of the optics. So, and the main reason to talk about that, to do our work about that, is because it's in the last years, we realized that the number of new cases of pediatric lithiasis, it's increasing. And here we have this study, showing that especially in the teenager girls, it's increasing. For example, we can take a look here in the 80s to nowadays, it had an increase of threefold in the number of new cases. Therefore, the urological societies, they have spent more time talking about this disease and how manage these situations. And here I bring European Association of Urology guideline of 2018. And here we can take a look that if in the first moment, when we stop to look in the use of ureteroscopy to treat these patients, we only see ureteroscopy as a first-line treatment in the distal ureteral stones. However, when we take a deeper look in the situation, we realize that the ureteroscopy is a treatment that fits pretty well in different modalities of stones, with the exception of the 2 centimeters stones in the pelvis or Staghound calculi. We can think about the ureteroscopy. So the goal of this study is to evaluate this treatment in the Children's Memorial Hospital in Rio de Janeiro, estimates the stone free rate, which used here as 2 millimeters and of the size of the stone, and also to understand, to see the number and the percentage of complications that we have this study. But you can ask me, João, okay, we have the guidelines and we know what we need to do. Why talk about this? And the main reason I brought this paper from University of São Paulo to illustrate how is the mindset and how the Brazilian doctors deal with this situation nowadays. What's the main point of this discussion? The extracorporeal shockwave lithotripsy, the machines to this treatment, we have a few amounts of them in the city of Rio de Janeiro, also in São Paulo, in Brazil in general. So what we should do in a reality like that? And basically, this study recommends that if you don't have the machine, you can have two approaches: or you buy a new machine, or you can think, for example, in buy others flexibles, semi-rigid to use in the patients instead of you have a new machine. And for example, 3 flexibles are cheaper than one machine of extracorporeal shockwave. And besides that, the single session of ureteroscopy is the stone-free rate is higher than extracorporeal shockwave lithotripsy, so the stone-free rate. So you can realize that in this reality in Rio de Janeiro, the treatment, the use of the extracorporeal shockwave lithotripsy isn't something that we can, obviously, if you have this in your hospital, the extracorporeal shockwave, keep using that because you are doing the correct thing, you are following the guidelines. But when you talk about my reality in Rio, we need to deal with the few resources and choose other things. And for example, we have especially with the new disposable devices, the outcomes they are improving about this treatment and the ureteroscopy. So more one reason to illustrate that the shockwave is something that's probably in Rio we want to even use a lot in the future. And here we choose the patients from 2017. We took the medical records of patients from 2017 to 2020. Patients, obviously, pediatric population, so less than 18 years old. The complications, we use the system of Cleveland-Zindo. And an important point is that patients who did the semi-rigid and the flexible, we exclude in the same treatment, we exclude of this study because we had the goal to compare the semi-rigid and the flexible. So patients who did both of them, we didn't use here. And here the complications. And I brought this paper to illustrate how the numbers of ureteroscopy, the use of the ureteroscopy is increasing along the years, while the numbers of shockwave lithotripsy is decreasing. And it's an American study, so talking about the new urologists, the mindsets of the residents. So, and then my study by itself. Here we had 20 patients, 12 female patients, 8 male patients. The mean age was 90.35 years old. The youngest patient was 2 years old, the oldest 15 years old. And you can ask, João, patient with 2 years old, you don't believe that's too young to do a ureteroscopy in this patient? And here I bring this paper to talk about to illustrate that the age by itself isn't a limitation. You can have, for example, patients in this study, they had a patient with 10 years old, younger than our, and it was okay. The main point is the ability of the urologist to perform the procedure, and if you have the appropriate instruments to do that. Almost all stones in our study were unilateral. And here I bring the mean size of the stone, the size of the stones. One of the stones in the end, you can see that Staghound calculi. Unfortunately, it's one thing that I'd like to show you, the problem sometimes with the documentation that we have in our city. During our study, we had a transition of the paper, the system, it wasn't digital, so we had an interesting study, a patient with Staghound calculi, bilateral stone calculi, the child with 2 years old, but we didn't have the documentation of the size of the stone after the PCNL, because the Staghound calculi was before they was approached with PCNL, then the remaining stones we used the ureteroscopy. Here we have we use we have 60% of the case with the stones in the distal ureter and 20%, which is 4 cases in the proximal ureter and 4 cases in the. We didn't divide the location of in the kidney, for example, lower pole, upper pole, pelvis. We compose of. My screen isn't appear here.
Yeah, this went back to the title screen. Sheila, can we get that back to his screen?
I'm pulling it up now.
Okay. Okay. So we didn't divide the patients between the kidney localization, if it's upper pole or pelvis, we documented all of them as in the kidney. And then you can realize the 12 patients with the kidney stones in the distal ureter, they were approached with, you can see in the other graphic, with 12 semi-rigid treatment, and 8 and the patients with the stones in the kidney or in the proximal ureter, they were approached with the flexible. 3 patients in our study, they did the PCNL previously, and to illustrate the reality here, how it's uncommon the use of the shockwave treatment. Any of the patients in the study, they were submitted to the shockwave. So we divide the patients in our study in the semi-rigid group and flexible group, and then we took a look also in the total number of patients. You can see that the mean age in both studies, in both groups, are pretty similar. In the end, the mean age of our study was 90.3 years old. And take a look, for example, in the size of the stone. The patients in the semi-rigid group, the size of the stone was smaller than the group than the size of the patients with stones in the flexible, which is we understandable, especially because smaller the size of the stone, longer it can travel in the urinary tract, and in the end, the mean size of the stone of the study was 7.7 millimeters. And here we also have we decided to a look in the mean number of procedure, which is really important when we talk about the ureteroscopy. And 1 procedure per patient were done in the semi-rigid group, which illustrates pretty well why the distal ureter stones we use the ureteroscopy is the first line treatment. And about the flexible, it was pretty different because almost 2 procedures per patient to achieve this during this study. In the end, 1.35 procedures per patient in our study. So here we have the number of procedures per patient. 75% of the patients in this did 1 ureteroscopy, 20% 2 ureteroscopies, and only 1, which represents 5% of the patients, did 4 ureteroscopies. This patient was the patient with the bilateral Staghorn calculi, a pretty complicated case. So, here we have the mean time of each procedure. Obviously, the flexible is a procedure that usually we need to travel longer with the ureteroscope, so it lasts more time. And the mean number in the end of the study, the mean time in the end of the study was 67 minutes per procedure. The stone-free rate, fortunately, we had luck, especially because our number of cases, it was a small number. We had 100% of stone-free rate after the proposed treatment. However, when we talk about the stone-free rate after only 1 procedure, we can realize that in the semi-rigid group, we had 100%, but the flexible group, we had 37.5%, which is in 8 patients in this group, only 3 of them we achieved the stone-free rate after the treatment, which represents in the end 75% of the patients in this study with achieving the stone-free rate after 1 procedure. And here is to show the group A, which we decided to call the patients in the semi-rigid, and the group B, patients which were treated with flexible. talk about the complications, we can see that the semi-rigid group absolutely no complications, and the flexible group was responsible for all complications that we had in the study. One of retropelvic junction stenosis, and the other one was a hematuria, persistent hematuria, more than 3 days. We represent 25% of the complications in the study, and the total 10% of complications. So here's to show about the complication that we had. Important to talk about that the OPJ stenosis, it was in the case of the bilateral staghorn calculi, we can tell precisely if this complication was caused by the number of treatments that we had or by the inflammation they associate with her stones. So, but we decided to include because it's a chance the post-operative treatment in this patient, so it's important to talk about. And then hematuria, it's a Clavian grade 1 Clavian complication, and UPGA grade 3 because it will require pyeloplasty. It's required the pyeloplasty in the future. So. And then certain points I'd like to discuss with you about the use of the stents. In our study, we use the stent in all patients after the procedures. It's something that we can talk about that because the literature recommends that you should use the stent depending on the time of the procedure, the number of times that you pass the ureteroscope inside the urinary tract. So talk with my department there. It seems that's okay. We take this care, but we need to do some certain kinds of reflections if we are not overstenting the patient. And about the length of stay, all patients in our study, they stay in the hospital for 24 hours after the procedure, and then we discharge them, except the patient with the persistent hematuria, which remains in the hospital until we resolve this manifestation. And something that I'd like to listen to your opinion at the end of the presentation, because my experience in Yale, I could see that we maintain we discharge the patients in the same day. I'd like to know how do you do, for example, in patients in the pediatric population. If you maintain this patient there, or if you discharging them. So keep moving. We also have discussion about the passive dilation and active dilation. The passive dilation, it is the pre-stenting to dilate the ureter, and then we approach this patient with a better size of the ureter to become easier to pass with the ureteroscope, or you can do active dilation. In our study, we did not use the passive dilation. We have absolutely no problem to do that, but it wasn't necessary. The AUA doesn't recommend the passive dilation as a routine in our patients. You need to take a look if you need or if you don't need. And the active dilation, how we did that? In the first year, the study is 2017 to 2020. In the first year, 2017, we used the balloon to realize the dilation, and after that, the hospital did the acquisition of the sequential dilators, the coaxial, and then they improved the dilation. You start to use these instruments to do the dilation of the patients. So, and we had 20 patients, 11 patients in the study, we need to do the dilation. The other patients, it wasn't necessary. Here I bring this study about it's a systematic review. It's a length systematic review with almost 3,000 patients. They divide the patients in the centers. Median centers, which is centered with less than 50 cases, and the high volume centers with higher than 50, which they have a higher than 50 cases. And we use this study to compare our numbers with the literature, using this study to compare our numbers with the literature. And we can see that our mean age, the mean of our age was similar, the mean size of stone similar too. But when we talk about the stone-free rate, we had a difference. We had 100% of stone-free rate after our procedures. They had 94.1. However, it's important to illustrate that we had a small number of patients. We had only 20 patients, while this study has almost 3,000. So if we had more patients, much probably would have case that wouldn't be able to remove the stones. Talking about the mean number of procedures, we had 1.35, they had 1.1 in the medium volume centers and 1.3 in the high volume centers, which is pretty similar. The percent of complications also pretty similar. We had 10% of complications in the total of the study, and they had 11.2. When we talk about the percentage of grade 1 Janeiro complications, we had 50%, they had 69. Obviously, if we had more cases in our study, much probably we would have more complications and no basic complications like hematuria, fever after procedure. So our number of this kind of complications would increase, and probably our number of grade 3 complications also would decrease, which is this study showed. 69% of grade 1 and 31 of grade 2 and 3. And when we take a look in the Clavian 4 and mortality, we can realize that even in our study and this systematic review, we didn't have this kind of complications, illustrating that the ureteroscopy in the pediatric population is, despite the fact that we had complications, it fits pretty well, and we don't have grave problematic complications. Here, I talking about specifically our patients which were submitted to the semi-rigid treatment and comparing them with a systematic review of semi-rigid. This systematic review is an excellent systematic review with more than 600 patients, and then we can see that our mean age is relatively similar, and the size of the stones in our study, we had smaller stones than them. So, and our sonography rate was higher, 100%. The same thing that I said before, the number of patients was a limitation of our study. We hope that in the next years, we will increase this number to do other studies talk about that. And complications also, fortunately, we had absolutely no complications in this group, while this study had 8.4% of complications. Here, talk about the flexible and compare the flexible group with other systematic review. The systematic review had more than 400 patients, and our mean age is pretty similar. Size of the stones also pretty similar. And about the sonography rate, our sonography rate was superior than them. The same points about the amount of patients in our study. And in this case, we had more complications than them. One of our complications, as I said before, we don't know exactly if it was because of our number of procedures, our 4 ureteroscopies, or if it was because the stagnant calculi that this patient had. So here I bring a table, and this table is in the Campbell, the chapter of management of pediatric reduced disease. I recommend for any of you that would like to take a look at this topic. It's a pretty good table, taking some other studies and evaluating also some of the topics that I talk in this presentation. And to conclude, it's important, we conclude that the ureteroscopy is an excellent treatment for the pediatric population. Obviously, exists difference between the semi-rigid and the flexible. Because of that, the semi-rigid using the distal ureter stones is the first line, but you can use the flexible too with excellent number of sonography rates. But in general, it's a pretty good treatment. It's a safe procedure. Obviously, we have complications with that, but the kind of complications are manageable complications. So we can use in the pediatric population, especially in a reality like mine in Rio de Janeiro, that we have a few number of proportional with lithotripsy machines. So if you, for example, in the case of Yale, that we have the machine there, keep using the correct thing because we are following the guidelines, the best for the patient. And to conclude, I bring these topics because I'd like to know the opinion about the use of the shift. In our study, we didn't use the shift in the patients, but for example, patients in this case, talking with the doctors in this hospital, I could realize that we use the shift some kinds of patients higher than 12 years old, which use that. The predilation, if it's something common to use in the pediatric population, if you prefer to use the predilation or do active dilation, and also they use the stent. One important point that I could realize during my sub-I is that it was very different from what I saw in Rio, is that we don't have the habit to use the strings in the patients in Brazil, and here is much common. I don't know if it's because of the instruction of the patients in Brazil, the level of education of certain kinds of patients pretty low. So in general, we don't use the strings, and we let the stents in the patient for 2 weeks in the patients usually. And here it was 3 to 5 days, sorry. So I'm open to questions, and thank you everyone to your attention.
Hi, this is Sarah Lambert, one of the pediatric urologists. I think that was a fantastic talk. I have one quick question. How were the various studies in managing or assessing their stone-free rate in the pediatric patients? If you already said that, I apologize if I missed it.
So in the last, if you talk about, for example, when I took a look in our review of the literature was 2010 and forward, and we had some because we need to divide between the semi-rigid and the flexible, but it was higher than the 50 systematic reviews for the semi-rigid, but it depends on the size of the place. And for the flexible, it was a smaller number. If I'm not wrong, you have some kinds of 30 systematic reviews. Sorry, study of a bunch of studies, but in the end, the number of systematic reviews I need to take a look exactly, because a big systematic reviews like I use in this study, we had a few amounts of them. We have something around less than 10 big systematic reviews, and can talk about specifically about this disease.
João, thank you coming back and giving us a talk. This has been great. I was going to ask a question, but first I think Dr. Lambert meant, how do you confirm this stone rate? Are you using CT scan or ultrasound?
So we use ultrasound if you have problems. If we are not sure about we use the ultrasound, you can use the KUB. Certain patients, when we have, for example, an emergent situation and we are not able to identify the ultrasound, we can use the low dose CT scan, but it is something that we need to have a high criteria to apply in these patients, because we are talking about pediatric patients. But in general, ultrasounds and certain situations, we use the KUB.
I just wanted to ask one last question. I know time is short, but do you have an age limit when you would consider using passive dilation pre-stenting versus actively? Because I'm always hesitant to actively dilate a very young child. Is your mentors worried about that? So
I take a look. We had a excellent study. I didn't include in this work. Talk about the use of, for example, of the shift in patients with less than 20 kilograms, which is less than 40 pounds. An Italian study. So the active dilation by itself, it isn't. You don't have a specific age to don't use that. You know, in our experience in Rio, in this hospital, talking with the doctors there, they usually, for example, if you realize that it's much more related to the weight of the patient. Patients with less than 30 kilograms, 20 kilograms, they stay concerned with that, but it isn't something fixed. You know, we need to have studies to improve our knowledge about that.
Thank you. Thank you again for coming back. We enjoyed having you here and visiting with us.
Thanks so much.
Quick question for you. Nice talk. And for you and our pediatric colleagues, I'm curious, does pediatric population tolerate stents better, worse, or the same as adults? And does their ureter dilate as much as an adult? Does it get to the size of like an adult ureter?
So I had a good surprise with that because in the first, when I began to study about this topic, in the first moments, I thought that the pediatric patients, they had more problems to deal with this stent. But talk with my professors in Brazil and also talk with Dr. Hiroman, gathering some information, I realized that the pediatric patients, they deal better with the stents than the adult patients. So it's really interesting.
All right, thank you very much, Joe. So next we're going to have Cassie Schuster from Florida State University College of Medicine. And she's going to be talking about the role of hyperbaric oxygen therapy in hemorrhagic cystitis associated with hematuria, and is it justified?
All right, thank you, Dr. Kellner. So good morning, everyone. My name is Cassie Schuster. For those of you that I have not met, I'm currently a 4th year at Florida State University. And before I begin, I would just like to thank Dr. Kim and Dr. Hiddleman for the opportunity to rotate at Yale this past month. I've really enjoyed my time here and appreciate how welcoming and willing to teach everyone has been. I also wanted to thank Dr. Arlen for helping me brainstorm ideas for my Grand Rounds topic, and then Dr. Kenny for all of his advice throughout the process. Today, I'll be talking about the role of hyperbaric oxygen therapy in hemorrhagic cystitis associated with hematuria, and is it justified? I decided to pick this topic because the majority of my undergrad research focused on hyperbaric oxygen therapy after spinal cord injury, so I thought it'd be interesting to kind of see the role it could play in hemorrhagic cystitis. So the goal of hyperbaric oxygen therapy is to deliver oxygen to targeted tissues at high pressures to increase the amount that's dissolved systemically. For the most part, individuals will receive treatment where the oxygen is administered 2 to 3 times higher than atmospheric pressure, and there's multiple proposed mechanisms of action. The first being anti-inflammation, angiogenesis through vascular endothelial growth proliferation, fibroblast activity, which helps increase collagen production. It's been hypothesized to help expedite the tissue and wound repair. It increases macrophage and lymphocyte activity, which is necessary for the natural regenerative process. And it's also been demonstrated to have bactericidal effects by its direct action on bacteria through the free radicals. Specifically with hemorrhagic cystitis, the 2 main mechanisms of action are angiogenesis and fibroblast activity. So when I was conducting my literature research, I came across many conditions that have utilized hyperbaric oxygen therapy to some capacity. However, for the sake of time today, I'm just going to focus primarily on hemorrhagic cystitis, but I wanted to note the other conditions I found. This includes Fournier's gangrene, interstitial cystitis, male infertility, acute kidney injury, and chronic pelvic pain. So the 2 main causes of hemorrhagic cystitis are radiation and chemotherapy, with cyclophosphamide often being the culprit. Some less common infectious etiologies include bacterial infections such as E. coli, Staph saprophyticus, and viral infections such as adenovirus. However, these are commonly found more so in immunocompromised populations. The clinical presentation for hemorrhagic cystitis is highly variable. Some patients will present with mild hematuria and bladder irritation, and this can range to gross hematuria with life-threatening hemorrhage requiring multiple blood transfusions. Individuals often also complain of lower urinary tract symptoms, such as urinary urgency, frequency, dysuria, and suprapubic pain and pressure. As far as acute radiation cystitis goes versus chronic radiation cystitis, acute radiation cystitis is defined as the onset of symptoms anywhere between 3 to 6 months after their last radiation treatment, and chronic cystitis is defined as anything with the onset of symptoms after 6 months. So anyone that presents with hematuria must undergo a very thorough workup to make sure you're ruling out any other causes such as UTIs, kidney stones, or tumors prior to diagnosing hemorrhagic cystitis. The workup usually includes urine culture and cytology, cystoscopy, and upper tract imaging to look for any masses or stones. Radiation cystitis is estimated to have an incidence of roughly 6.5 to 9% in patients who underwent standard radiation for either prostate or gynecological malignancies, and it's estimated to have a mean latency period of 35 months. However, this could be highly variable. Some predictive factors that put an individual at an increased risk of developing radiation cystitis include the total amount of radiation they received, the dose per fraction, and the volume of bladder that was radiated. The mechanism is damage to the vascular endothelium. This will go on to form fibrosis, cause tissue necrosis, as well as hypoxia. Neovascularization also occurs, which can lead to the irretractable hematuria that many individuals suffer from and can significantly impact their quality of life. And then here in this picture from cystoscopy, you can see the neovascularization throughout. Treatment for radiation cystitis can be very challenging for a urologist. For the most part, conservative measures are utilized at first, such as stabilization if necessary, and continuous or intermittent bladder irrigation. If that fails and the patient still continues to have persistent hematuria, they often require cystoscopy, clot evacuation, and fulguration. Some systemic medical therapies, such as WF10 and sodium pentosan polysulfate, have been used in radiation cystitis. However, they have a very large side effect profile and long-term effects aren't well established with them. Intravesical formulas such as formalin, aluminum, and hyaluronic acid have also been used. Formalin has been known to have many serious side effects, and hyaluronic acid is on the newer side, which has been demonstrated to kind of mimic the glycosaminoglycan layer within the bladder to help regenerate collagen. Ablative measures can also be used to help control hemorrhage, such as laser and argon beam. And then you have hyperbaric oxygen therapy. And if the patient continues to have persistent hematuria despite alternative treatments, sometimes surgical intervention is necessary, which would include urinary diversion with or without a cystectomy. So when I was conducting a literature search specifically for hyperbaric oxygen therapy for radiation cystitis, I found that there was poor quality of the data. The majority of the literature is in the form of non-randomized retrospective reviews or case series, which would constitute this as level 4 evidence. The majority of them were small single-center studies. And the first time it was documented that hyperbaric oxygen therapy may have a role in radiation cystitis was in 1985. And this was based on a case series of 3 patients who were diagnosed with hematuria, underwent hyperbaric oxygen therapy sessions, and then all had resolution of hematuria, as well as improvement of macroscopic changes of the bladder on cystoscopy. A systematic review that I found that was published in February of 2020 found roughly 20 papers of individuals that have undergone hyperbaric oxygen therapy for radiation cystitis. This comprised roughly a total of 800 patients, and they found that the response rate to the therapy treatments was between 20 to 100% based off very subjective outcome measures. So I think this definitely highlights the importance and need for more standardized randomized control trials. However, I did come across the first randomized control phase 2-3 trial for hyperbaric oxygen therapy, and it was specifically for radiation-induced cystitis as well. It was published in Lancet Urology in September of 2019 by a Swedish medical group that spanned over 5 Nordic university hospitals. And the fact that it is a randomized control trial classifies this as level 1 evidence. However, it's important to note that this was an unblinded study. So this introduces a lot of bias when interpreting the data. The inclusion criteria for patients included them having to be diagnosed with radiation cystitis per study protocol, which was conducted by a urologist based off cystoscopy findings, physical exam, and then exclusion of any other causes. All individuals were 18 to 80 years old with pelvic radiation completed greater than or equal to 6 months prior. They all had to score less than 80 on the urinary domain of the expanded prostate index composite score, and they all had to have a referral for hyperbaric oxygen. Exclusion criteria included refractory bleeding requiring blood transfusion, if they had a permanent urinary catheter, if they had a bladder capacity of less than 100 milliliters, if there was a fistula present, or if they've previously received any hyperbaric oxygen therapy sessions. And the fact that refractory bleeding requiring blood transfusion was considered an exclusion criteria, this already eliminates a big portion of individuals suffering from radiation cystitis that may benefit from this therapy. So this limits the generalizability of the findings to begin with. The Expanded Prostate Index Composite is a patient-answered questionnaire designed to evaluate patient function and bother after prostate cancer treatment. However, specifically, the urinary domain has been validated for use in both males and females. It's comprised of a 12-question questionnaire asking about certain urinary symptoms over the last 4 weeks. And then for each urinary symptom, the patient will answer whether it caused no problem all the way to a big problem. At that point, their score will be converted to a 0 to 100 scale, with a lower score correlating to more severe symptoms. This also raises another potential concern in the study because it's only eliciting symptoms that have occurred in the last 4 weeks. So for example, if an individual was hospitalized a couple months ago for a large episode of irretractable hematuria requiring multiple blood transfusions, but now their urine is clear, this may not accurately capture the population characteristics. As far as the study design goes, all individuals that met criteria and were eligible underwent a screening visit, which they had a cystoscopy, physical exam, and baseline assessments performed. At that time, randomization occurred, and randomization was stratified by sex, if they had a history of any type of pelvic surgery, and the last time that they received radiation treatment. At that point, they were randomized into either the intervention or the control group, which was called standard care. Visit 2 comprised the intervention group of receiving all of the hyperbaric oxygen therapies, and then visit 3 was a safety assessment only given to the intervention group after their last hyperbaric oxygen session. Visit 4 was a follow-up visit in which all patients underwent a repeat cystoscopy, physical exam, and baseline assessment. And the time between visit 1 to visit 4 was roughly 6 to 8 months after randomization, and the primary outcome that they looked at was absolute change in total epic urinary score. For individuals in the intervention group, they underwent a total of 30 to 40 sessions 5 times a week, which already puts a really big burden on the patient in order to be compliant with the therapies and make all of the sessions, and the sessions were really 80 to 90 minutes long. A total of 87 patients were screened and enrolled, and after randomization, 7 dropped out of the standard care group, while only 1 dropped out of the hyperbaric oxygen therapy group. I think this is due to the fact that individuals in the standard care group were informed that after the trial period, they were able to undergo hyperbaric oxygen therapy, so they dropped out in order to seek treatment earlier. With the sample size already being pretty low, if those individuals that dropped out of the standard care group had the most severe symptoms, this could have definitely skewed the data. A total of 79 underwent an intention to treat analysis, and the majority of individuals in both groups were male, and the primary malignancy was prostate. And the average time from radiation to inclusion included roughly 4.1 and 4.4 years. So as I previously stated, the primary outcome was absolute change in total urinary epic score, and utilizing a post hoc calculation, they determined that a change in 9 points in epic score was the minimal clinically significant difference. So in the hyperbaric oxygen group, they saw a change in 17.8 points in epic score, while in the standard care group, they only saw a change in epic score of 7.7 points. The difference in group means had a p-value of 0.013. So while these findings are statistically significant, I found it very difficult to translate how this would actually play out in a clinical setting, especially since they're utilizing very subjective outcome measures here. The epic urinary domain is also subdivided into 4 different categories, which includes bother, incontinence, hematuria, and nocturia. The paper stated that statistically significant improvements were observed in the bother and incontinence category. However, there was absolutely no mention of any data regarding hematuria symptoms and if those changed at all pre and post intervention. And with my question today being specifically looking at hemorrhagic cystitis with associated hematuria, that provides little insight into being able to answer that. Based off individual improvements and values, utilizing the EPIC score and whether or not they saw a 9-point change in their score, they were categorized into 3 groups: improved, worsened, and no change. In the hyperbaric oxygen therapy group, 73% were considered improved. However, I think it's really important to note that this was an unblinded study. So individuals in the intervention group were aware that they were receiving the treatment, which could have skewed kind of their perception of symptoms as explained by the placebo effect. I think it's also interesting to point out that in the standard care group, 34% improved despite no intervention at all. And we also do not know what they improved in and to what capacity. So for example, an individual may now have complete resolution of their urinary urgency and frequency symptoms, but if they're still suffering from persistent hematuria, I wouldn't consider that a successful outcome and improvement. Macroscopic changes in the bladder were also analyzed pre and post intervention utilizing the late radiation morbidity grading scheme, which was developed by the radiation therapy oncology group. So during visit 1 and visit 4, an unblinded urologist would perform a cystoscopy on all patients and write up the operative findings. A second blinded urologist would then review those operative findings, and they were responsible for assigning a grade for each patient. We were not given any baseline characteristics, so we don't know what the grades were for the patient starting off with, and we also don't know if what the average grade was for the hyperbaric oxygen therapy group versus the standard care. So they reported that 64% improved grades. However, we don't know if those patients were improving from grade 4 to grade 0 or grade 2 to grade 1, which would definitely have a different clinical impact. So just to kind of sum up some of the study flaws I talked about, this was an unblinded study, which leaves room for bias for both the investigator as well as the participants. The fact that 73% saw improvement with the hyperbaric oxygen therapy could be explained by the placebo effect. This also brings up the concept of regression to the mean. So while it may seem that there's an association between individuals that received the therapy and then showed an improvement after, we don't really know if those individuals were already going to improve on their own. This could be explained by the fact that 34% in the standard care group saw an improvement despite no intervention at all. So we're really not able to tell if these patients were going to be getting better on their own. We also don't know the long-term effects. So while many may have resolution of symptoms now, these could recur later on down the road. And patient standardization was also an issue. The majority of patients received 30 to 40 sessions, however, that varied. So some patients that received 30 sessions and some patients received 40 sessions. And we don't really know if that would have had like a statistically significant impact on the outcomes. Smoking status was also not controlled for, which could have impeded the hyperbaric oxygen therapy from exerting its maximal therapeutic benefit. So just to wrap up with some takeaway points to conclude, there is poor quality of literature for hyperbaric oxygen therapy for radiation cystitis. And while the treatment is usually safe and well tolerated, it puts a significant burden on patients, both from a time commitment perspective. For example, in the paper that I just analyzed, it's stated that 30 to 40 sessions were required 5 times a week, which puts a big time commitment on the patient from a cost perspective, with it not always being covered by insurance, and from an availability perspective as well. The impact on quality of life remains unknown. So while this is definitely a feasible treatment for individuals that may have hemorrhagic cystitis with persistent hematuria that have not responded to alternative treatments, it should definitely be recommended with caution. And there is definitely need for further research to help fully uncover the therapeutic benefit of hyperbaric oxygen therapy for hemorrhagic cystitis. So to answer my question for, is hyperbaric oxygen therapy justified for hemorrhagic cystitis associated with hematuria, my answer would be no, currently. Thank you, and I'd be happy to answer any questions.
Cassie, thanks for a great talk, nice summary, and I think it's commendable that you were able to identify a relatively high quality study to answer this question. We see a fair amount of radiation cystitis and other forms of cystitis with refractory hematuria. And although we do have an adjacent institution at Bridgeport Hospital that has hyperbaric oxygen therapy available, it is always a little bit of a challenge to get them there. Few questions regarding the study. Did you discuss what standard care was within the control group? An ideal placebo situation would be that they put them in the diving chambers and don't do anything. And then you can actually say, oh, the placebo effect or, in their urinary symptoms is a true placebo effect as opposed to the natural history resolution of their symptoms. Secondarily, I think, it seems like one of the confounders of this study is that inclusion criteria was referral to a center like this, and usually it's a last-ditch effort after many more local therapies have failed. Wondering if they had any discussion about timing of therapy as far as making it like a first-line or early-line therapy as opposed to after multiple intravesical therapy options have failed.
Yeah, absolutely. And those are great questions. And honestly, a lot of them weren't provided in the study. As far as like the standard care group goes, it was just stated that they did not have any intervention at all. So they weren't unblinded. They weren't blinded. So they weren't put in a chamber. They also stated specifically that previous treatment modalities were not controlled for. So many of these individuals could have had intravesical therapy prior and exhausted all the alternative treatments and are now coming for hyperbaric oxygen therapy. So to answer the question about like standard care, it wasn't specified as to whether or not they were receiving any other treatments, but they were not undergoing hyperbaric oxygen therapy during that time period. And then what was the second part of your question again? It was regarding,
like it seemed, what would you say? The median time was about 4 years to treatment.
yeah.
Did they look at, I mean, they probably didn't, you would have mentioned it, but those who were intervened on earlier as opposed to those who were on the latter half of that range?
Yeah, so that was the only table given for patient demographics, and there wasn't a range given for the average time besides the average, besides like the 4.1 to 4.4. So we don't know, but based off the other case series and retrospective reviews that I did come across, it seemed for the most part, the earlier implementation of hyperbaric oxygen therapy, the higher therapeutic benefit they've been seeing. Is there specifically a cutoff? I'm not exactly sure, but that was kind of the take away from what I saw from other very small select case series.
And then it being an intent to treat, did they say how many people dropped out of the therapy arm, given how onerous it was?
Yeah, so only after randomization, they considered the intention to treat after the individuals from randomization dropped out, but then after that point, they were considered in the intention to treat analysis, and only 4 dropped out from the hyperbaric oxygen therapy group. 1 was for commitment, just like not being able to make the appointments. 1 was for someone had a recurrence of malignancy somewhere else, and then 1 had barotrauma, but they didn't require any intervention, and the other had some kind of like hereditary like optic condition, so they weren't able to tolerate the hyperbaric oxygen therapy well.
That's pretty good compliance.
Yeah.
Thank you.
Cassie, they excluded patients who had severe hematuria needing transfusion, things like that. I was wondering if you could comment on if that might impact generalizability to our patient population.
Absolutely. I definitely think it does impact generalizability for the findings, given that individuals that are sometimes candidates for hyperbaric oxygen therapy and are being recommended for hyperbaric oxygen therapy are often the ones that have failed many alternative treatments. So they may have tried intravesical therapies, systemic therapies, cystoscopy, clot evacuation, and they're still having persistent hematuria. So by excluding that group, you're really eliminating the ability to uncover the true therapeutic benefit that would have for those. So if those individuals have the most severe hematuria, although they may not have complete resolution of symptoms, as opposed to someone that's starting off the treatment with mild hematuria. They could definitely have some type of clinical benefit. So I think it definitely limits the findings of the study significantly.
But I mean, someone could argue, hey, listen, there was that case, that first case series that showed that if you, in these 3 patients who had really severe problems, you give them the treatment and then they got better. Isn't that an argument that hyperbaric oxygen works?
Yeah, that's definitely an argument, but I don't think, as far as like using like objective outcome measures, like what you have resolution of hematuria, but you could have recurrence, you know? So I think there's a lot of room to argue that and kind of uncover more.
Cassie, I really enjoyed your talk. So it's a quick question on, by the way, are you back in Florida or are you still here?
I'm still here. Mhm.
You're still, okay. Can you comment on the standard of care, that arm, you know, what kind of treatments did they get as a comparison to the hyperbarics?
So the standard care was just any appointments if they needed, but they were not given any other treatment modalities. So while the specifics were not stated and it was just told that they did not receive any intervention, it was not explained specifically if they had received any other treatments. When they were randomized, it stated that previous treatment modalities were not controlled for. So it could have been very well that both groups had some type of treatment previously, but during the standard care, which was considered the control group, no, they were given nothing.
Okay, so not even, so again, these patients had radiation cystitis, so they're not just hematuria. They had urge incontinence, so not even anticholinergics, or there's nothing going on that we can tell.
They could have very well been prescribed it previously, but it didn't mention specifically what they had received. It just had, and it specifically stated, I think, that the treatment modalities were not controlled for previously. So that could have definitely impacted being able to kind of uncover who benefited the most from the therapy.
Okay. Do we, you know, using our, just as a question for our faculty members, you know, since we have this epic, can we get our institution experience on this? Pat or Dr. Kenny or anybody?
Yeah, I mean, we could, yeah, because I mean, our institutional experience would really, the vast majority of them would have been referred to Bridgeport. So I'm sure we could get Bridgeport and then the diagnosis codes and then the billing codes from the hyperbaric. And I would imagine that we could put together a population of patients that were treated. I think Cassie's point, I think, is really interesting about you know, the limitations of the retrospective looks at whether or not it works with the because of regression to the mean. I think it's I think that was a good point, Cassie, about why randomized trials are so necessary.
Absolutely, thank you, Dr. Kenny.
Hi, all. David Hess here. Cassie, great talk. And to Pat and Isaac's point is, you know, I think in certainly the community practice in New Haven, there's a huge experience with hemorrhagic cystitis, and it's been ongoing for a long time. I think there's not a day that goes by that I don't see at least one person with that in my practice. And it seems like there's always someone in the hospital with this issue. So it is a real problem, and I think it's been poorly studied, and I think we should work aggressively to try and capture all these patients, not just from Bridgeport, but from the entire greater community that we serve.
I think Bridgeport is one of the main referral centers, though, right? I don't know of anywhere else that is doing this. So, I mean, I know we've sent all of our VA patients to Bridgeport, for example.
I think does a lot of it
I think
too.
there's a place in Mid-State also that does hyperbaric. It's
And
someplace
also Griffin Hospital right down the road in Derby.
in Hartford does it too.
And also Milford. So Milford, Griffin, Bridgeport, Middlesex, in Middletown. There's several centers that have this.
We do it in
What
Greenwich
question are you gonna-
too.
But what question are you going to ask? I mean, we know they had bad hematuria before they went, and then we treated them, and then most of them are going to get better, right?
Well, I think the first number is get the N, you know, see what the prevalence of it is, and then work from there.
Yeah, I think the issue would be, you know, how are you going to measure outcome? if you were to look at it retrospectively. And I've had a couple of these patients, one of whom has had to go back. So, one of my thoughts would be if you have to be re-hospitalized for gross hematuria, that's a pretty definitive outcome. And I've had some limited success with it, but it's hard to tell if it would have gotten better anyhow.
So to that point, Harris, then if we were to execute a randomized trial for the patient population we're at discussion here, if they have refractory hematuria, I mean, we don't have an alternative, right? I mean, that's what we're sending them to Bridgeport.
Well, I mean, the alternative is more aggressive therapy. Obviously, formally, we're trying to avoid that. Yeah, I'm just thinking. I mean, just off the top of my head, how one would design that type of trial.
Yeah,
I think it would be lowering the threshold to sending patients with, persistent hematuria to them, because if they're only getting the worst cases, you're not going to really ever understand the breadth of patients that could be treated with this, and really establish a true inclusion or ideal criteria.
I think you'd have to have non-patient measured objective outcomes, like you said, Harris. It could be visits to the emergency room with the chief complaint of hematuria, number of patients or times that they go on CBI, blood transfusions, go on to have some other intravesical therapy, and see if there's differences between the two arms in each of those categories. You probably don't need a giant N to be able to detect differences if you have those as primary or secondary outcomes.
I mean, you could make a a combined metric perhaps, but I mean, I think that introduces some potential problems. I think you definitely would have to take into account the idea that a significant number of people are going to improve on their own without the intervention, and you'd have to compare not the improvement in each individual arm, but you'd have to compare the arms to each other, right? Arm 1 versus arm 2, as opposed to improvement within arm 1 versus improvement within arm 2, like Cassie pointed out.
I think this just kind of highlights the importance of using more objective outcome measures, because for the most part, all case series and retrospective reviews have been using subjective questionnaires and patient perceived symptoms, which makes it really kind of hard to tease out where the true therapeutic benefit lies, especially with a majority of these patients that may be hospitalized are going to be getting better at some point on their own.
Cassie, why don't you come by my office? Let's talk about this trial. All right.
Absolutely.
Okay.
All right. Thank you, everybody. Great job, Cassie. Great job, Joe.
Thanks, everyone.
Great job. Really enjoyed it.